Hello, hello. Hopefully everybody can hear me. Hopefully everyone can hear me. So, yes, just doing a little test run here, seeing how this works. Trying to do a lot more lives when it comes to YouTube, right? Have to touch into this platform. I like the platform a lot, so might as well go live on this platform, see how it goes. But yes, I just take too much time editing videos. I realize I take so much time editing so many videos. That's mainly why. Yeah, mainly what happens there. But nevertheless, let's go. Let's run a couple of drills and reviews and see exactly what happens, where it takes us. There's so much topics, so many things that we should know. Definitely. I should take this link and drop it to my class. Let's see, is there a way I can extract the link? Yes, there is. Copy video link. Copy video link. Nice, nice, nice. Okay. Let's see. Yeah, let's run a drill. Let's run a drill. Yeah, let me see. Definitely, I'm gonna put this here. Put this here. Let's post this link. Let's see what happens. Oh, I can hear myself. Hello? Not good, not good. I don't like it. Why is it playing back? Oh, I know why. All right. Kind of random. Hello, hello. Yeah, so I'm just gonna go over some stuff. Let's see. So much material. Let's see. Yeah, interestingly enough, the other day in my class, we're talking about the differentiation of the gonads. Always a good class just to touch up and remember. So many people seem to get things wrong. The differentiation of gonads. What actually makes them change? The whole XY process. That opens the door to endocrinology. Because endocrinology, you have all those androgens. You have to know what differentiates all that development. So it is interesting, but SRY gene. SRY gene is found on the Y chromosome. So only, I guess, males can possess this type of gene, and it codes for. And I always mention every time I talk about coding, I always like to mention a little bit of how transcription happens. But typically, if you have like, let's say, you have your DNA strands, right? You have your DNA strands. There's going to be a specific type of gene that will express itself, of course, but this process is heavily regulated. You have enhancers, repressors, different types of proteins that will either allow you to bind here or basically inhibits this process. So remember, enhancers are they going to stimulate promoter regions. Promoter regions, promoter. So in this case, promoter region is accessible by transcription factors. Transcription factors bind the promoter region. Then you have RNA polymerase 2. Always mention it, always regurgitating that. But RNA polymerase 2 is going to allow coding. You're going to be able to synthesize your mRNA strand. And we call that the process of transcription. Transcription. Just understanding that can get you points. Transcription. It's the fundamentals. A lot of questions are just built on the fundamentals. Like if you understand how transcription happens, definitely it's great. But yeah, remember, eukaryotic cells, all this happens at the level of the nucleus. Prokaryotic cells, this doesn't really happen at the level of the nucleus. And if you ask somebody why, well, the answer is because prokaryotic cells don't really have nucleus, right? Their genetic material is just out there in the cytoplasm, readily available. So anyway, mRNA tends to leave the nucleus, undergoes this process. I always say child protective services, CPS, capping, poly-A tail, and splicing. You have spliceosomes, introns and extrons. The introns stay inside. The extrons are going to leave. They reassemble and they leave. So really, mRNA is just a group of extrons that have gotten together. So mRNA then leaves the nucleus, and mRNA has to code, right? It has to translate this nucleus, this genetic material into actual proteins. So what proteins is it going to actually make? It's responsible for making a specific type of protein. Specific type of protein. So I'll draw here 60S, 40S. Specific type of protein will be TDF, testes differentiating factor. Anyways, TDF will go and will differentiate these gonads into testes. Okay, let's go super fast. So testes. Testes have two different types of cells. You have the Sertoli and you have Leydig. Sertoli and Leydig. Sertoli will do MIS. That's MIF, inhibin B, inhibin B, and spermatogenesis. Spermatogenesis. Ladies and gentlemen, spermatogenesis. Leydig, its major responsibility is to put out androgens, testosterone. So yes, testosterone is responsible for differentiating that mesonephric duct, the Wolferian duct, into seed, seminal vesicle, epididymis, ejaculatory duct, and ductus. It was a ductus deferens. Definitely, all this will differentiate the Wolferian duct. Wolferian duct, also known as a mesonephric, but that has to be done by testosterone. If testosterone is working, then you'll have the proper differentiation of these features. Super important. So really quick, now that we mentioned testosterone, let's extrapolate as much information as we can about this testosterone. First off, let's target it from the angle of pharmacology. There's so many different things when it comes to anti-androgenic therapies, right? So many different types of anti-androgenic therapies. So first off, we're going to see that the hypothalamus basically builds a strong relation with the pituitary glands. This is going to build a hypothalamic pituitary gonadal axis. This is truly done, most finalized during the process of puberty, right? During the process of puberty. So yeah, you're having your anterior and your posterior pituitary. Let's look at it like this. The GnRH is what will stimulate your anterior pituitary gland in order to release FSH and LH. Perfect. So there is a way to inhibit the GnRH in particular. So if we're looking at this from a pharmacology type of angle, let's understand this. We could actually inhibit GnRH using the physiology of, particularly of the endocrine system. Remember, the endocrine system, when it comes to glands, if you actually stimulate the product, let's say the product is testosterone here, right? This whole hypothalamic pituitary gonadal axis, it's actually trying to make you have testosterone. That's the product test. So if I give testosterone, automatically I send this negative feedback, turning this thing off, basically turning off this whole system. So the product inhibits the actual axis. The hypothalamic pituitary gonadal axis is inhibited by the product. So if, for example, and this is the whole thing about endocrine is very interesting. It kind of follows the rule of biochem. This is a specific type of rule where if you have a high levels of substrate, decreased level of product, you're going to have the incentive to synthesize more product. But that same rule goes backwards as well, meaning that if you have too much of product, let's say too much testosterone, you automatically inhibit the conversion, the enzymes, whatever would catalyze the reaction to make more products. You'll naturally inhibit this. So let's take a look at how that looks. If, for example, a patient is on exogenous testosterone, you will inhibit GnRH. You will inhibit GnRH. You can see this with anabolic steroid abuse. Any patients that's on any kind of anabolic steroid abuse, you'll notice that they kind of turn off their whole entire hypothalamic pituitary gonadal axis. It turns off. And that is very dangerous because they have to turn it back on in order to have proper spermatogenesis. So they can risk issues with their synthesis of testosterone. Many of them can go on TRT therapy afterwards. right? But anyways, point is that if you give exogenous testosterone, you can inhibit this access. Now, there's also a purposeful way that we can give a type of drug, specific type of drug that will turn this axis off as well. And it also depends on how you administer it. There's this pulsatile way of giving GnRH, let's say, in order to mimic regular synthesis. Or you can give low dosage for longer periods of time in order to turn this whole axis off. That's the whole idea behind GnRH. So the type of drug that they're giving is an analog of GnRH. It's called leuprolide. Leuprolide. So the logic here is that, hey, if I give GnRH, just enough GnRH to turn off this axis, not enough to go stimulate the FSH, LH, and the anterior pituitary, but just enough to let the body understand that we do not need this axis to be active. If I can do this for a long term, then I successfully shut off the hypothalamic pituitary gonadal axis. I turn it off finally. If I do this for a long enough time. So definitely this is done in a purposeful manner, right? GnRH. Now, there's also ways you could, moving on, that's GnRH. The next thing we see in this whole pathway here with the anterior pituitary, you don't want to mess too much with the anterior pituitary. So we look at the products, like what does actual FSH stimulate and what does LH stimulate? Always remember, guys, LH is the easiest to remember because I can look at it like this. L for Leydig, right? H for Theca. So depending on female, male, if it's male, we're talking about male, could expect to see Leydig stimulus with LH. Female, you have your Theca cell. That's what LH will stimulate. This is important, so you can remember this naturally. And by default, if this will stimulate Leydig and Theca, I could easily think FSH. FSH will be the opposite. So we're saying here, Leydig and Theca, we could easily say, okay, well, FSH, granulosa, and Sertoli. Let me put this here. Granulosa, Sertoli. So that has to make sense. That makes sense. Remember that. Okay, so point is this though. We're talking about pharmacology here. If you have testosterone, let's say you have testosterone, and you actually want to inhibit the binding of testosterone to wherever it's supposed to bind. Of course, you have androgenic type of receptors, androgen receptors. If you want to make sure that these receptors cannot sense your testosterone, there's different drugs that you can give to target this, right? You have drugs like flutamide. Flutamide looks a lot like finasteride. Everybody gets confused with that, but nevertheless, flutamide. So you can block this receptor with flutamide. All right, so what else? You also have cyproterone. It's kind of like testosterone. You see that? Terone, but it just has a cypro in front of it. That's also going to work as an antagonist to androgen receptors. Oh yeah, spironolactone. Spironolactone tends to have this effect as well. You guys remember spironolactone? Spironolactone. I can tell you one thing about spironolactone. The mechanism of action. So this is why we can say it blocks it, because its mechanism of action is very familiar to us. It's basically an antagonist. It's an antagonist to aldosterone receptors. So let's understand, ladies and gentlemen, where in the world does aldosterone work? How does aldosterone work? Let's just go do a small little deviation here. Yes, definitely. Let me just tell you. Aldosterone, second messenger system. aldosterone. Its second messenger system is the system that involves, of course, the intracellular receptor. You'll see this intracellular receptor at a cytoplasmic level, right? And normally it has heat shock protein binded onto it. But when aldosterone enters, it's able to displace the heat shock protein. It's able to displace it. So you'll have aldosterone sitting on this receptor, intracellular receptor. I'll put it right here, aldosterone. All right, so aldosterone, it's able to enter as a complex into the nucleus. Inside the nucleus, we do have genetic material. So what does it actually do? It's going to upregulate those genes, right? The expression of the genes, I should say, that will code for mainly three channels. I'll tell you which one. And an enzyme. So 3 channels. What channels are these? First channel, I should tell you, ROMK. I'll tell you another channel, ENaC, and sodium potassium ATPase. ENaC, ROMK, ENaC, sodium potassium ATPase. These are the 3 channels that are involved with aldosterone. Aldosterone will upregulate the genes that express the mRNA for these channels. So you'll be able to basically synthesize your mRNA, transcription, and then, like I said in the very beginning of the class, you'll be able to translate that mRNA into these 3 channels. Okay, I also mentioned an enzyme. So you'll realize the carbonic anhydrase. So yes, carbonic anhydrase. You guys remember this enzyme, very important. You can actually take something like H2O and carbon dioxide and make carbonic acid. And then you'll catalyze another reaction where the carbonic acid can become this proton, hydrogen, and bicarb. This is carbonic anhydrase. So notice how it's doing this dual function here. So this actually happens. Now let's look at the actual physiology of this. If we were to connect this to physiology, what in the world is happening? Well, okay. You have something called principal cells, right? In those tubules at the collecting duct system, you'll notice there's something called principal. I should put it like this. Principal, I think that's how you spell it. My spelling is not too good. Cells. Principal cells, basically. Remember, since you have upregulated your ENaC channels, ENaC will be present right here, ENaC. And then you also have ROMK. The responsibility of ENaC is to reabsorb sodium from the urine. So you're reabsorbing sodium straight up from the urine, putting it inside that principal cell. And then you have also ROMK. The responsibility of ROMK is to excrete potassium out into the urine. And then I also mentioned sodium potassium ATPase. So let's put that channel right here. Sodium potassium ATPase. All right, perfect. So that's what you basically have in that sense. That's all because of aldosterone. Now, let's also include the alpha intercalated cell. We say alpha, A for alpha. A is the first letter of the alphabet. So what does that help me remember? Well, if you look at this disease called renal tubular acidosis, type 1. This is the pathophysiology involved with renal tubular acidosis type 1. It's basically a dysfunction of the alpha intercalated cell. Yes, you have to try to memorize all these things. So A is the initial letter of the alphabet. That reminds me about the RTA type 1. That's the whole pathophysiology behind RTA type 1. If your alpha intercalated cell is not functioning, you'll have RTA type 1. Also, I should mention A also reminds me of the word acid. This indeed is the cell responsible, like I mentioned before, for taking H2O, for taking carbon dioxide, converting it into carbonic acid, and then converting this carbonic acid into hydrogen, and bicarb. Now, bicarb gets reabsorbed into the bloodstream, of course, in exchange for chloride. Exchange for chloride. It gets reabsorbed. And hydrogen gets kicked out of this alpha-intercalated cell and put right into the urine. So this is the mechanism of aldosterone, is how aldosterone works. So why in the world is this connected to testosterone? Well, I'll tell you. They do look very similar at a molecular level. They look very, very similar because they come from the same precursor. They're all coming from cholesterol. Right? You have desmolase, basically breaking down your cholesterol, metabolizing it into different types of hormones. At first, in the first stage, remember you have your glomerulosa, your fascicularis, and reticulara. Remember GFR, glomerulosa, fasciculata, and reticularis, I think it was called. Those three. Remember that the glomerulosa, here you would be able to make your aldosterone, mineralocorticoid steroids, aldosterone. Then the fasciculata, you can make your cortisol, which will break down to corticosterone, cortisone. Again, zone, esterol, own, testosterone. Look at how they kind of sound similar. So, okay, we continue. Then you have the reticularis. This is more of the sexual type of hormones. So remember, when we look at sexual hormones, let's go from least potent to most potent. Here you have your DHEA is the weakest one. Androstenedione is a bit stronger. Androstenedione. And then you continue testosterone. You continue one more, DHT. Remember, guys, that DHT at a peripheral level, testosterone can get converted to DHT at a peripheral level by the enzyme 5-alpha reductase. And this drug in particularly can be inhibited by, this enzyme in particular can be inhibited by something called finasteride. Finasteride. This is what they're giving all these guys so they won't go bald, right? Finasteride. They're giving these type of medications in order to prevent male pattern baldness because DHT is the one that's blamed for this androgenic male pattern baldness. Okay? So remember that. Now, DHEA. This is a very particular type of hormone if you think about it. Because think about it. Males are making it, females are making it. But we have to be able to know if this comes, where this comes from. Does it come from supraadrenal gland, or is this coming from actual production of our gonads? So there's one way to differentiate. Especially it's important to know with females, because you want to understand if any kind of androgenic, let's say any kind of androgenic expression shown on a female, you want to know if it's exogenous, endogenous. Not only that, you also want to know if it is endogenous, which gland is producing this? Is it the ovaries? Is it the supraadrenal gland? So remember, DHEA, if you guys end up seeing it with an S on it, it's coming from the supraadrenal gland. It's coming from the supraadrenal gland. If it's just straight up DHEA, then it's safe to say made from the gonads. Yes, sir. Yes, indeed. Okay, let's continue. But anyways, like I was saying, if we look at GFR, the R part was the androgens. I'm just going to write androgens around here. Made a whole nice little list down there. Androgens. So they tend to look the same. They all have the same second messenger system as well. They enter right through, they permeate right through the membrane. right? They have high levels of permeability. They go right through. Not only do they go right through, then they also bind that intracellular type of receptor. Once they create this complex, then they're able to go inside the nucleus. When they go inside the nucleus, they upregulate certain type of genes that they want to transcribe. You transcribe the genes will exit the nucleus into the cytoplasm, and they would translate utilizing ribosomes that are found in the cytoplasm. Simple. We understand that. That's how they work. So androgens. So think about it. If I give a drug, the drug we were talking about before was the drug specifically, was the drug flutamide. Drugs like spironolactone. So remember this. If you have a drug like spironolactone, we said that spironolactone, you spell it correctly, I think, can actually work as an antagonist to aldosterone. So it would actually bind to where the aldosterone receptors are located. It will bind to this area. So it shouldn't be so far-fetched to think that it might make a mistake and also bind, also have some slight affinity to androgenic type of receptors, right? Because they come from the same type of molecular structure, from cholesterol, very similar type of molecular buildup. You'll notice they both have permeability. Yes, definitely. They both have permeability right through the cell membrane because of their lipid-like consistency. So yes, it will also bind. So yeah, that is true. Another side effect, definitely remember gynecomastia, all these type of issues related. But if you look at spironolactone, yes, it can cause blockage of androgenic type of receptors. So keep that in mind. Definitely super important. Okay, so wow, we got all into, okay, so now that we went to the pharmacological aspect of it, of spironolactone, I should also mention though, that this is classified as a potassium sparing drugs. So there is a mnemonic out there for you to remember. Potassium sparing drugs, you have SEAT. Yes, like a chair, like a seat, definitely. S is for spironolactone. Of course, we remember that. E is for a pleuronone. I'm just going to write pleuronone. My spelling's not too good. A is for amelioride. T was for triamterene. So one thing in particular that we do need to know about this is that S and E are having the same mechanism of action. These two will have the same mechanism of action. They are antagonist to aldosterone receptors. That's how they are functioning, right? Now, the bottom two, amelioride and triamterene, they actually inhibit ENaC inhibitors. They are ENaC inhibitors, ladies and gentlemen. That's how they are doing their mechanism of action. They are directly going and blocking the ENaC. Now, something very important about ENaC is that in order for it to function properly, it has to function through electronegativity as well. So there is an actual current that gets built up between ENaC and ROMK, sodium, potassium. The actual flow right here is important to understand. So if you inhibit ENaC, you automatically inhibit ROMK. By inhibiting one, it's like a system. They kind of work together at that level. Something's going in while something's going out. They create this pull. So if you inhibit one, you automatically inhibit the other. So why am I telling you this? Well, it's important in one aspect that I will mention right now, in this weird side effect of TMP. Ladies and gentlemen, TMP. Remember trimethoprim. Trimethoprim mechanism of action inhibits dihydrofolate reductase in these bacteria, right? In these prokaryotic cells. That's the way it functions, TMP. TMP has a weird side effect. It could actually inhibit ENaC. If it inhibits ENaC, well, when it inhibits ENaC, it will cause a increase in potassium. So patients can have hyperkalemia due to administration of TMP. I know it sounds crazy, but hey, it's true. So also, the main drugs that we were talking about right now, we just mentioned amelioride and triamterene. They could inhibit ENaC as well. Okay. Perfect. So yeah, there's so many weird and crazy side effects. So many weird and crazy side effects out there, just for you to know. So yes, ladies and gentlemen, testosterone. Now, the last thing I'll say about testosterone, is that testosterone also becomes estrogen. It can get aromatized. Aromatase. Definitely aromatase. So there are drugs that inhibit aromatase. If you know the drug, type it in there. What is the drug responsible for this? Let's see. Strone. So anastrozole is one of the big ones there. Yeah, there's so many. There's a lot of them. Aromatase inhibitors. Anastrozole. There's one with the L as well. Letrozole. Yeah, letrozole. These are definitely going to inhibit the aromatization of testosterone. Okay, good. We understand that. That was good. Good. All right, so now let's jump on to a whole different type of topic. I'm going to mention some side effects, some things. We'll mention the drug that's related to the side effect. We're done with testosterone for now. That was good. We mentioned of how it's synthesized, how it comes out, how Leydig cell, all that. Now let's take an approach. Let's talk about different systems, different things. Let's jump around as much as we can. Okay, so let's get bipolar. So I'll ask you guys. I'll tell you guys. QT prolongation. So a lot of people just know the main A, B, C, D, E, F type of stuff, right? A, B, C, there's antiarrhythmics that can cause it. Yeah, that was a good ride. That was a good one there. They definitely ondansetron, right? You have antiarrhythmics like 1A. Let me just write them down. 1A and 3, right? 1A and 3. You have antibiotics like fluoroquinolones, and also macrolides. You also have antipsychotics like cyprasidone. Also antipsychotics like risperidone. I call it risperidone because risperidone has high risk for everything. I'm just straight up calling it risperidone. It can cause weight gain. It can cause extrapyramidal symptoms. It can cause that hyperprolactinemia. It will cause every single side effect that you can relate to antipsychotics. Definitely risperidone is there for you to cause, right? To complicate stuff. Definitely. All right, you have A, B, C, then you have D, antidepressants, SSRIs, and also TCA, definitely. E was for antiemetics like ondansetron. You mentioned that already. Ondansetron. And then F, you actually had fungal antifungals. I remember can you mention which one with the F? Do you remember? This one they are including this one. I hate that this has a little delay on it. See if I can fix it. Ketoconazole. They also have fluconazole. Last I seen fluconazole as well. Okay, fluconazole, just because I saw that one. Fluconazole. Okay, good. Now, let's mention some extras so you don't fall for their tricks, because it's like, hey, is this good enough for me to know and that's it? Like, is that enough? Let's be a little more sincere. There's a couple of more other things that can cause more of these type of complications. So let's take a closer look. Arsenic poisoning. Arsenic poisoning. Arsenic poisoning. Definitely. What else? I would also include opioids, right? Opioids. Definitely. Things like morphine. So opioids. Opioids. All those type of opioid medications. Yes. Definitely remember that. Right? Torsol to the point, QT prolongations. Definitely. More than 440 milliseconds in men. Definitely. Also, you'll see this with electrolyte disbalances, like in hypokalemia and also in hypomagnesemia. So if you have a decrease in potassium, decrease in magnesium, what drugs can give you a decrease in potassium? Remember, amphotericin B. Amphotericin B can give you a decrease in potassium. Yeah, diuretics could particularly give you a decrease in everything in that sense when it comes to all those different types of electrolytes. Definitely. But yes, this is what you see. So what is the actual treatment, the management of torsades de pointes? So it is considered a ventricular arrhythmia, right? They call it a polymorphic type. Ventricular arrhythmia, polymorphic. And the treatment is magnesium sulfate. But if the patient is hemodynamically unstable, what do we do? What do we do if he's hemodynamically unstable? Stabilize the membrane of the cardiac. Defib, yes, defibrillator, that makes perfect sense. You want to do some defibrillation on this patient without a doubt, definitely. Okay, remember that if the patient is hemodynamically unstable, for hemodynamic unstable patients, expect to see a systolic blood pressure less than 90 and a diastolic blood pressure less than 60. Or a diastolic pressure less than 60, I should say. Okay, let's continue. So yes, this is what you see at that sense. So arsenic poisoning is very interesting there. Keep that in mind. All right, so let's see the next one. I'll tell you, yes, there's also, so jumping on to the next thing, basically, let's just jump on to the next one. That was a good little ride there, right? QT interval prolongation and all that was nice. There's so many things there. We start getting into all the different aspects, like antiarrhythmics, especially 1A. So let's take a little look. 1A, you have things like procainamide. So we have to be aware of the side effects of procainamide. What can procainamide cause? You guys remember? What can it cause? It can cause antihistone antibody positive lupus, drug-induced lupus. Definitely. So that is very dangerous in that sense. So what is the problem with drug-induced lupus? You'll see that you'll have a problem, basically, with the overexpression, because you cannot mute. So you have an issue muting. So your methylation process is hindered. Remember, in epigenetics, if ever in the book You look at the first aid, you'll see they have a small section of epigenetics. They talk about the process of methylation and acetylation. Methylation is muting, basically packaging up your histones, making sure that you cannot express genetic material. So that genetic material cannot be manipulated, cannot be transcribed. So methylation has to do with muting. And acetylation has more to do with activation. So whenever you see that histones are acetylated, they get relaxed. When they're relaxed, that means you can now intervene, you can bind to the genetic material, you can now promote transcription of different types of genes. So with procainamide, you have an issue in methylation. So you cannot methylate. That's a huge problem. Because if you cannot methylate, you'll have an overactivation of particularly some proteins that should not be active. Why? Because our immune system can bind to these type of proteins. So that's what's happening with the drug-induced type of lupus. You're having your own immunoglobulins binding to our own proteins, basically, forming complexes, right? This is what type of hypersensitivity is this? I would ask you. Hypersensitivity. Sensitivity. So it's type 3. It's type 3. Yes. So like with haptens, you see more of a destructive process, right? You bind to them, then they get destroyed. With this, they'll bind to it like more of they form a complex, right? You remember in type 3, what ends up happening is that once you form a complex, naturally you don't see such a quick reaction, but when they accumulate in certain spaces, then you'll have complement that would be able to react to that complex. Things like complement, remember complement reacts here, would be able to then promote some kind of activation. So then you'll see it'll be pro-inflammatory. And then a pro-inflammatory issue would occur wherever it has accumulated, usually a lot of it in the kidney. So this one thing I should tell you though, when it comes to drug-induced versus non-drug-induced lupus, is that the drug-induced lupus does not really have a manifestation at the level of the kidneys. So it looks just like lupus, except for that whole manifestation of the kidney part. There is no kidney issues there, okay? Just because it's so acute in that sense that doesn't really have time to cause that hyperaccumulation of complexes that would then react at the level of the kidney. So that's something to look out for. That's what differentiates those two. So it's anti-histone antibody. While lupus, you'll see ANA positive. You'll notice anti-Smith, right? And what else can I tell you? So yeah. That's what you have there because of a lack of methylation. When you don't have methylation, you'll express some genes that would code for proteins that are reactive to our immune system. That's the pathophysiology behind drug-induced lupus. And in all reality, the major drug, there's one drug that has high risk for drug-induced lupus. That will be hydralazine. Hydralazine, remember the drugs that are given to women who have hypertension during their pregnancy. So you have his mom never lies. His mom never lies. HMNL. That's hydralazine. That's alpha methyl-dopa, nifedipine, and labetalol. These are the drugs there in that sense. Good. So, all right, let's continue. So procainamide is also given for Wolff Parkinson's White. Remember Wolff Parkinson's White? You have basically, normally when you have depolarization, it should come from the SA node onto the AV node, right? Here's your P wave. This is where you're going to get your QRS. So from the AV node, you'll notice there's has of his. And then this will have left bundle branch, right bundle branch. And then you'll have Purkinje system in order to send the depolarization current towards both ventricles, right? And remember, this is happening, this depolarization is actually happening during an isovolumetric contraction. So if we look at it at the level of, we try to graph it out in a chart, try to remember, you are going to have this stage right here. Let me make sure I emphasize on this. This graph here, this loop system that we have here. One thing that does stick out is that you have a very strong isovolumetric contraction occurring here. This is the process of systole. This is the process of systole. And it's super important to understand that this is a QRS, basically. Super important to know that here's where you're consuming the majority of oxygen. This is where your heart will contract to the maximum and try to extract as much oxygen as it can from the blood system. So if you're having angina, it's going to happen here in this stage, in this isovolumetric contraction. Let me put the parameters down here so it can make sense. Let me put volume, and then let's put pressure up here. And also, this is where the vessels have less perfusion. So let's be very clear. While you are contracting, the vessels are prone to have less perfusion. So it's like a really difficult job there. There's a couple questions on UWorld on this concept. That during a powerful contraction, you tend to have less perfusion. Yet, nevertheless, this is the actual stage where you're having the maximum consumption of oxygen. You're using all that blood in order to have a proper contraction. Because if you look at systole, what is systole? Systole is just the idea of the left ventricle overcoming that threshold pressure that was set to the aorta. So if the aorta has a pressure of 140, let's say, then you must create more pressure inside that ventricle in order to override that 140. That's the rule of pressure. Pressure always travels from high to low. So that means in this left ventricle, I must be able to create more than 140 in order to open up the aorta. So how do I do it? There's only two mechanisms that will help here. One is based on more volume. If I am able to get more volume into this limited space, then the pressure will automatically increase. The other system is limiting the space. So either you increase the blood that's going into the left ventricle, also known as preload, or you decrease, let's say, the space, the actual chamber space. Okay, so let's understand what in the world is that? That's what we do during contraction. During contraction, notice that the actual heart tissue is constricting. It's limiting the space. It's making itself smaller and smaller. By doing this, you automatically increase the intraventricular pressure. That's what a contraction really is. So whenever this depolarization is going on, you're going to notice that there will be a strong contraction in this muscle tissue. And this contraction is really mediated by calcium. So I could regulate the strength, also known as inotropic measurement, by increasing calcium. So calcium during the plateau phase, any calcium that you could increase in that stage will definitely give you a positive inotropic effect. So there's drugs like dobutamine, for example, which will bind beta-1. Beta-1 second messenger system was GS. GS activates adenylate cyclase, which will increase the ATP conversion into cyclic AMP. That will activate protein kinase A, which at the end of it all, I should just tell you, this gives you an increase in calcium. If you have an increase in calcium during the plateau phase, you'll have a positive inotropic effect, meaning you'll have a powerful contractility. So let's remember one thing. Stroke volume is CAP, C-A-P. It's contractility, it's afterload, and preload. Those are the parameters, the characteristics of stroke volume. That's how you would manipulate your stroke volume. So going back to what I was mentioning, during this phase here, isovolumetric contraction, isovolumetric contraction. And this is how you should read all your cardiac graphs. Always look for this stage. How do I know how to find this stage? This is the same stage that has the maximum volume. And it's also the same stage that the pressure just shoots up and it reaches threshold. It surpasses threshold. By surpassing the threshold, you enter into the ejection phase. You have a rapid ejection phase and then you have a slower type. So this is the most important stage, I would say, in the whole cardiac cycle. Well, it depends what you look at as important, because diastole is also very important because you need to basically allow the blood to make its way into the ventricles, right? You need to have that relaxation. So, okay, this is basically it. This is what you see here when it comes to this. Remember, beta 1 stimulus is what's going to increase calcium. Take a look at all this and how this works. So when we were looking at, we just mentioned Wolff-Parkinson's White. I'll just tell you, there could be ectopic foci, like the bundle of Kent, that can produce electrical stimulus towards Purkinje system, leading to a spontaneous, let's say, contraction, right? And instead of it going from AV node, has of his, left and right bundle branch, and then Purkinje, it just went straight up Purkinje. So what ends up happening? You end up seeing a different type of wave, a delta wave. It skipped all that nodal stimulus, which would have gave it a small dip for Q, R, S. Instead, what you're seeing here, that Q will not have that dip. You just see straight up a delta wave. That's how you have the production of delta wave. Delta wave. So yes, this is what you see. That's Wolff-Parkinson's White. So why did I mention Wolff-Parkinson's White? Because the treatment is procainamide, right? Procainamide. That's a 1A antiarrhythmic. So it's kind of crazy, but this is something that you guys should know, this whole cardiac loop and how it works. Oh, 1 second. Got a quick phone call. Hello? Yeah, sorry. Oh, wow. People are texting me all night. They're talking to me about that Mike Tyson fight. Guys, who do you think is going to win? Who do you think is going to win? What's up with Mike Tyson, man? He's kind of old. Mike Tyson is kind of old, guys. He's about 60 years old. And what I remember from 60-year-old men is that if they receive trauma in the brain, in the head, they are prone to have epidural hematoma. Right? That's dangerous. That is kind of dangerous, right? Epidural hematoma. Remember, this is the type of hematoma that will increase your intracranial pressure, and this can lead to herniation, brain herniation, transintorial hernias. Remember that transintorial brain herniation? These are the ones that will have cranial nerve 3 manifestations. So one thing to understand about cranial nerve 3 manifestations really quick. Cranial nerve 3 has 2 different types of nuclei that we need to understand. You have the Edison-Westphal nucleus. Then you have the general somatic efferent. So whenever you are coming from the outside and pushing this, you'll end up having damage. Let's say you'll end up having Edison-Westphal nucleus problems. Edison-Westphal nucleus problems, these are related to something we call blown out pupils. So you'll see blown out pupils as the manifestation of cranial nerve 3 damage. If you look at general somatic efferent, these are the types of fibers that are actually innervating the system of the eyes, but the, let's say, the somatic movement of the eyes, right? The medial rectus, the inferior obliques, the type of muscles that are innervated by cranial nerve 3. All this is coming from the general somatic efferent. So if you have damage of the general somatic efferent, they generally call this down and out. So if it's something that's pushing from the outside, then we can definitely say this is going to be a Edison-Westphal nucleus problem first. And if the problem gets even worse, then we'll start to see that it will manifest itself in the general somatic efferent. Now, remember, it is opposite if we're talking about patients who are having any kind of ocular issue related to diabetes. Because diabetes, you'll see, is something that impedes the irrigation system of many different tissues, especially including the skin as well. Remember, you have all that, there's a lot of amputees just because of diabetes. So think about it like this. If the patient is diabetic, they'll have an issue when it comes to having proper perfusion of the vessels. You know, I used to always tell patients, when I used to take patient history, I would tell them, they would ask me about all these drugs, and they'll ask me about diabetes. I worked with a nephrologist before, and a lot of patients are diabetic patients. A lot of patients are obese patients. It's obvious. Why? The two most common causes of chronic kidney disease is diabetes and hypertension. So if I'm here working with these patients, they often ask me, hey, how does diabetes cause like amputation, like necrotic limbs? And I would explain to them, hey, you ever dropped soda before on the floor? They say, yeah. So I tell them, well, if you ever drop soda and you leave it there for long periods of time, notice how sticky the floor can get. Notice how you are basically changing the consistency, right, to a very sticky type of consistency all over the floor. And they'll say, yeah, sure. Well, think about it. If you have high amounts of sugar circulating in your body for very long periods of time, uncontrollable amounts of sugar, you're definitely going to have some kind of glycosylation process. This glycosylation process will make it hard for vessels to be able to dilate properly. It'll make it hard for blood distribution to properly make its way to irrigate the superficial type of tissue. So if you think about it like that, look at the eye. It's like this Edison-Westphal nucleus area will have proper irrigation, but then when we examine the general somatic efferent, which is a more centralized type of neural well, I'm just going to say nucleus. It is. It's a cranial nerve 3 type of nucleus. It's more centralized. So it ends up getting less irrigation. And if that's the case, then you'll notice that if the patient is having some kind of diabetic issue, if there's any kind of ischemic problem, what type of nucleus would be affected first before? It'll be definitely general somatic efferent without an Edison-Westphal nucleus problem, meaning that the patient can have down and out, but without blown out pupil. That's what happens in irrigation and circulatory system problems, as opposed to patients who have hernias, tumors, anything that's pushing, anything that's increasing intracranial pressure, anything that's causing a mass effect. If it's pushing the cranial nerve 3 nucleus, then it's definitely going to cause first an Edison-Westphal nucleus. Edison-Westphal nucleus problem. And then as it gets worse, it will finally cause a general somatic efferent. So notice the difference between that. Definitely. And remember, 1 second, got another phone call. Hold on. Hello, everyone. Yes, sorry. Yeah, somebody's calling me. I guess the Tyson fight is about to start. I don't know. So it is 10 o'clock. I guess we're going to leave it here for now. Definitely going to leave it here for now. I'll catch you guys next time. Thank you, everybody, for joining me. I have 4 million people live. It's awesome. Amazing. 4 million people here. Definitely watching the class. Thank you. Thank you. Definitely. I'll catch you guys next time. And should I upload it? You guys tell me. Yes or no? Should I upload it or should I just delete this? Lost media. Because I don't really have the hang of it yet. I want to jump into this and have a whole bunch of, it'll be cool. There's a bunch of followers and we just here discussing medicine all night, right? That'll be awesome. But that's not the case. So I probably won't upload it. But thank you everyone for joining. Upload. Oh, Pablo. We got Pablo here. How long have you been here, Pablo? How long have you been here? You've been quiet. Just been observing everything from the bleachers. Pablo has been sitting in the bleachers. Yeah, that's what's up. That's what's up, though. Now I hate the fact that it has a delay. I gotta learn how to take out the delay. But yes. Thank you, everyone. Thank you, everyone. I'll upload it. You know what? I'll upload it. Thank you, everyone. I'll catch you guys next time. Thank you for everything. Definitely, definitely. Have a good night. Have a good night.